I'm Answorth Allen. I'm an orthopedic surgeon specializing in sports medicine at a hospital for special surgery. I am currently the orthopedic consultant to the New York Knicks, an orthopedic consultant to USA Basketball. I'm the former head team physician for the New York Mets and medical director at St. John's University. I specialize in sports medicine with emphasis on knee, elbow, and shoulder surgery. The ACL is a primary stabilizer of the knee. This is the knee model. There are basically 4 ligaments around the knee. The 2 on the outside called the collateral ligament, the MCL on the inside, LCL on the outside. The ACL is in the front of the knee. It's called the Anterior Cruciate Ligament. The PCL is in the back. It's called the Posterior Cruciate Ligament. We have these 2 discs or shock absorbers called the meniscus cartilage in the knee. The ACL is the primary stabilizer of the knee joint. It prevents the tibia from subluxing relative to the femur. When the ACL is torn, the knee typically becomes swollen and the knee becomes unstable because the primary stabilizer of the knee has been compromised. Most patients will injure their ACL when they change direction suddenly, if they pivot on a fixed foot, if they jump and land incorrectly, or if they have a direct blow, such as in a football tackle. There's an audible pop or noise from the ligament rupturing. The knee gets swollen relatively quickly. It's usually quite painful, and most athletes are not able to bear weight on the extremity. Most high-level athletes, college, high school, or aggressive weekend warriors will need to have their ACL reconstructed, primarily because during athletic activity, the knee will buckle or give way when they change direction or move suddenly. The patient that we see with a torn ACL will get a thorough clinical evaluation. This includes a history, a physical examination, routine x-rays, and usually an MRI scan. The MRI scan will give you a definitive diagnosis of an ACL tear. Once the diagnosis is confirmed, a decision is made in discussion with the patients about the best approach for that given patient. Most patients will be referred for physical therapy to increase their range of motion and to decrease swelling in the knee. We also emphasize muscle strengthening prior to any surgical reconstruction. If the patient elects to have surgery, this is typically scheduled when the knee inflammation has calmed down and there's adequate range of motion of the knee. The risk from an ACL reconstruction include the risk of infection. Most patients will have some numbness around the incision site. Very rarely there's a potential risk of a blood clot, and there may be some pain from a donor site that the graft is taken from. When the ACL is torn, the ligament is usually ruptured completely. Essentially, the ligament explodes. Repairing the ACL by sewing the ligament back together is not a reliable way to address an ACL insufficient knee. Reconstruction involves taking a graft from somewhere, either from a donor or from your own body, and this is used to reconstruct the ACL. Graft options from your own body include a graft from your hamstring tendon, your patella tendon, or your quadriceps tendon. We tend not to encourage the use of donor grafts because of the risk of re-rupture of the graft. Most ACL reconstruction take approximately 1 hour from the beginning to the end of the surgery. And this usually includes not only the ACL reconstruction, but addressing any other associated injuries such as damage to the meniscus or cartilage injuries in the knee joint. The anesthetic used for ACL reconstruction is usually a spinal anesthetic supplemented by a local block. The patient will have the option of staying awake and watching the surgery, or if they choose to, they can take a light nap with a twilight anesthetic. Post-surgery, the patient is fitted with a brace and begins physical therapy in the recovery room. They'll be instructed in how to ice and elevate the knee to decrease swelling. They're taught how to use the crutches before surgery, and this is reinforced after the operation is done. They're usually referred to an outpatient physical therapist, usually within 2 days after the reconstruction is done. And again, the emphasis initially is on decreasing swelling, regaining knee extension, and gradually regaining knee flexion. We also focus on isometric quadriceps muscle strengthening. Usually the brace is worn consistently for the first 2 weeks. After the first post-op visit, when the wound check has been accomplished and the patient has adequate knee extension and the ability to lift the leg off the table, the brace is usually unlocked. By the second week, the patient will not need to use a brace when they're sleeping. Most patients will need crutches 2 to 4 weeks post-ACL reconstruction. Cryotherapy, or the use of cold application, is essential in the post-surgical period. This helps to decrease the swelling around the knee joint and also will often decrease the need for pain medication. The typical appointments post-ACL include phone calls the day after surgery to ensure that everything is set. The first post-op visit is usually 12 to 14 days after the operation is done. This is for suture removal and wound check to make sure everything is going well. The second visit is usually 6 weeks after the initial visit. They're usually then seen at the 3-month mark, the 6-month mark, and the final visit is usually around 9 to 10 months post-surgery when they're cleared to return to play. In the post-operative appointments, we assess the patient's progress with their range of motion, muscle strengthening, and the stability of the knee. Later on, we assess their function with a functional evaluation program. Most patients are able to run approximately 4 months post-surgery. At about 6 months post-surgery, they begin training to return to sports. We typically will do what's called a quality movement assessment to assess the patient's progress with rehabilitation, and usually they return to sports 9 to 10 months post-surgery. Most patients are able to return to driving within 3 to 4 weeks if surgery is performed on the left leg.